Hello, everybody. Thank you again for joining us today. We will be having a video presentation by Dr. Wang, and he'll be joining us live for Q&A at the end. And I'll let Karen start the presentation.
Hey, hi there. Good morning. My name is Dr. Raymond Wang. I'm a metabolic physician at Children's Hospital of Orange County, and I oversee the multidisciplinary lysosomal storage disease program there, which includes a large population of folks who have MPS 2. And so thank you to Kristen and Project Alive for inviting me to give a talk at the community conference about updates with regards to gene therapy. Sorry I couldn't be there live, but I will join the Q&A session. I just wanted to make sure that there weren't any weird internet issues. So I'm going to share my screen and we'll take it away. All right, so today, the topic of this talk is gene therapy results. I'm going to share results from two specific studies, which are likely to have broad interest within this community. Here are my disclosures. And I don't think I need to spend too much time on background for Hunter syndrome, just to know that there are genetic changes in the gene, which is abbreviated IDS, that codes for instructions to make the enzyme called iduronate sulfatase, which breaks down specific GAGs in the cells of the body. GAGs is short for glycosaminoglycans. They are complex polymers that contain a lot of sugars. And basically the purpose of iduronate sulfatase is to remove one part of that polymer called a sulfate group. And if you are missing iduronate sulfatase, you can't break down those GAGs. The GAGs build up in the body, and that's how you get the symptoms. So imagine that IDS is there to empty out the garbage. And if you can't empty out those waste products because you're missing the enzyme, then that's kind of what the inside of the cell looks like. The cell gets unhappy and gets sick. So in terms of clinical trials, I think the talk after me is already giving some background on this, but I just wanted to give a quick primer. I'm just going to let you read this, and I'm not going to read this out loud. And there will be further conversation in the talk that happens after me. Okay. All right, so we all know that for MPS 2, there's intravenous enzyme replacement therapy, which is basically synthetic IDS enzyme. It has to be given intravenously every week because it's like filling up a gas tank. You start to run empty and then you need to get filled up again. Because the body of a person who has MPS 2 can't make IDS enzyme, so you have to continually fill up the tank. Increasingly, there are Hunter syndrome patients, typically very young ones, who are getting what's called a hematopoietic stem cell transplant. That's where stem cells, which are often donated either from a member of the family or from umbilical cord blood, are then given to a patient. But before you do that, you need to make room in your system. It's affectionately called conditioning, but really it's giving high-dose chemotherapy to eliminate one's existing immune system so that these new stem cells can find their way into the bone marrow and what's called engraft, start making blood cells. But the most important thing, especially for MPS II, is that some of those stem cells go into the brain where they become the immune system inside the brain and are able to make enzyme, which can correct the neurologic manifestations of severe MPS II. So again, the idea of this study was to talk about specifically two gene therapy clinical trials in progress for Hunter syndrome. And basically, this is where a treatment which is thought to potentially help patients who have Hunter syndrome need to be tested or trialed for both safety and efficacy, whether the patients have like really serious side effects from the treatment, and then to test whether or not it actually works. And so that's where these two studies are. The first one is called Campsite, affectionately for MPS II. The gene therapy is called RGX-121. It's an open label study, phase 1, 2, 3 study. The medication gene therapy is given intracisternally. It's slated to enroll 48, and I think at the moment 25 patients have been enrolled. So I'm going to talk a little bit more about each one of these terms. So what is gene therapy? So we're talking about, I guess, like the filling up analogy. The idea of gene therapy is instead of constantly having to go back to the gas station and get filled up every week, gene therapy provides good copies of the IDS gene to a patient's body. They find their way inside the cells, and the IDS gene can then be used by those cells to make functional enzyme. And so instead of like going back over and over again to have to fill up, the idea of gene therapy is now you have the ability to make your own enzyme. And the hope for gene therapy is that it's a one-time dose, that you don't have to go back and keep getting dosed. So in order to deliver that gene, that good IDS gene, you need to have something called a vector. If you think of it like a delivery truck, that vector brings the good copies of the gene to the cells. This specific medicine is administered using a interventional radiology procedure where the medicine is injected into an area in the spinal cord called the cisterna magna. Now, where is the cisterna magna? It is this space right here, and you're thinking, oh my gosh, that's not a whole lot of space. But don't worry, there are very, very highly trained people called interventional radiologists. So this is our excellent interventional radiologist. That's me standing there ready to administer the gene therapy. But our patient gets anesthesia, lying face down, and then they use a CT scanner to basically assess where the administration needle is, and very, very delicately make tiny little millimeter adjustments to get into the space. It takes a little bit of training, but just wanted to remind you that, you know, these are people who are highly trained to get into very, very difficult spaces. And once we get into that space, then we can administer the gene therapy. The goal then is to deliver that gene therapy directly into the brain, which is the site of, you know, neurologic disease for severe MPS II. So what is this study looking at? It's obviously looking at safety. It's looking at GAG levels inside the CSF, the fluid that surrounds the brain. It's also looking to see if there are improvements in behavior and neurodevelopment. And then it wants to measure the enzymatic activity within the CSF as well as the blood. This was one of the outcome measures that was described, but so far it hasn't been reported. And for more details, here's the website. So I'm here to report to you the results because last time I was here, I could only tell you about what the study was. But fortunately, there are now results published. I know this is a terrible link, but this is publicly available. For part one, so there's part one and part two. Part one, 15 patients have been dosed. In part two, an additional 10 patients were dosed. The patients that were enrolled all had severe MPS 2. One of the other things about a part one gene therapy, phase one gene therapy study is that the company is looking for the right dose. You might be thinking, like, goodness, like, what happens to the folks who get the lowest dose? The issue with gene therapy is if you're going to use that vector, you can only give it really once. The vector is the outside shell of a virus. And so once your body has seen that virus, if you get it again, then the body's immune system is going to get rid of it. It's not going to be very effective. But because this is the first time this specific RGX-121 had ever been given to patients, one of the things that the FDA requires companies to do when they're doing clinical trials is to find the right dose, the dose that's able to accomplish its efficacy goals, and also to minimize side effects. And so far, 3 patients got dose 1, 7 for dose 2, and 5 for dose 3. Ultimately, dose 3 was the dosage that was settled at for part 2. And you can see how long these patients have been followed for, anywhere from up to 4 years to as little as half a year. So far, the study has been pretty safe. There were 14 what are called serious adverse events that required hospitalization. But really, the most important thing is to determine whether or not these hospitalizations were related to the gene therapy itself, or if they kind of happen very, very commonly to patients with MPS 2. And so here were the events, and really largely none of them were related to MPS 2, to RGX-121 directly, but mostly due to random illnesses and nothing to do with the medication. All of them were self-resolved. There were no patients that passed away during the study. There were some adverse events like, runny noses and various other things that popped up, but again, pretty safe. I'm going to spend a little bit of time explaining to you this graph because the marker, the GAG that was measured for the purposes of campsite, was a specific GAG called heparan sulfate. That's the GAG, one of the GAGs that builds up inside the brain and is thought to cause the neurologic degeneration in severe Hunter's patients. And D2S6 is just a fancy terminology for heparan sulfate. It's the heparan sulfate that builds up inside body tissues and body fluids of patients who have MPS. And so this is the y-axis. This is the level of the D2S6. And these are patients who have Hunter syndrome, severe neuropathic Hunter syndrome. You can see it's between probably about 160 and 300. These are normal patients down here, and so they were able to get CSF from volunteers that don't have Hunter syndrome and measure the D2S6. These are patients who have Hunter syndrome but no neurologic involvement. And so you can see here these various different colors, dose 1 being the lowest dose, dose 2 being the middle dose, and dose 3 being the highest. And BL is for baseline, and you can see after treatment, which occurs just after baseline, within about 8 weeks, you can see that the levels of D2 S6 in all 3 of the various different doses came down from where they were pre-treatment and were below the level of D2S6 that are seen in these intermediate sort of non-neurologically affected MPS II patients. The other important thing about this graph is that the reduction in heparan sulfate, D2S6, has actually stuck around for quite a period of time. And so in the low dose patients, dose 1, you can see that even after 4 years post gene therapy, that reduction has persisted. Dose 2 patients haven't been followed for quite as much time because they were mostly dosed later, but you can also see that trend remains even 2 years after treatment. And then finally, the patients who have received dose 3 seem to have the highest degree of decline in D2S6. And I think that's why the company chose to stick with dose 3 as the final dose for part 2. So this answers the question, number 1, is heparan sulfate being reduced by gene therapy? The answer is yes. Number 2, it helps to answer the question of how long does the therapy last? The idea for gene therapy, again, is supposed to be permanent. Well, we don't know how permanent it is until we actually run the clinical trial. And so you can see even after 4 years post-dosing, there is a sustained reduction. I know there's a big error bar here. Sometimes, when you do measurements, there are just some fluctuations up and down. So I wouldn't discount that. And most importantly, afterwards in year 3 and 4, that large amount of variation resolved. So that answers the question about does it reduce D2 heparan sulfate and how long it lasts. Next question is, does it actually help neurodevelopment? And so here, when they assessed neurocognition, the company separated the neurocognitive testing to patients that were essentially having severe developmental delay at the time of treatment and patients who did not have severe developmental delay. And so I'm going to walk you through what these graphs are. So here on the x-axis is what's called the chronologic age of the patient. That's basically today's date minus their birth date, how many months old they are. This is what's called a developmental age equivalent. And so the test that was done is called a Bayley Scales of Infant Development 3. That's a very commonly used neurocognitive test. You may be familiar with it. At the end of this cognitive test, it can be scored, and then a age equivalent developmental score for the patient can come out. For a child who is essentially developmentally normal, their age equivalent developmental age should be exactly equal to their chronologic age. And that's symbolized by this gray line right here and this gray line right here. So if you don't have any cognitive issues, you follow along this line. But not every child is created equally. And so this dark gray shade is considered essentially within 1 standard deviation on either side. Those are patients between the essentially kind of like the 23rd percentile up to the 87th percentile for development. In this case, the lower you are, the more behind you are. 2 standard deviations is about 3rd percentile here up to about 97th percentile. So if you follow this, you want the slope of your graph. You want to be able to gain developmental milestones at the same pace that your chronologic age is proceeding. And so essentially, you want to see a curve that continues, a line that continues to go upwards. You want to see a trend that continues on over the long term. And so you can see here, there's a patient that was treated, looks like it's about, hard to tell, about 12 months of age. This patient initially had really good neurodevelopment, even getting up to like, 87th percentile. And it's hard to follow these lines, but it looks like their development kind of plateaus off. This patient was treated at 36 months, is kind of at the lower end of normal for development, and has now gone off of this. So anybody who's kind of in this white area would be considered significantly cognitively impaired. But there are other patients like this one where their curve continues up, and would be considered within normal range. There is one patient who got the third dose, who might actually be gaining milestones at a faster pace. But that's the thing about clinical trials. We're still learning as we go, and so it's hard to draw any really great conclusions aside from the fact that it appears that some patients do benefit cognitively, and for the others, we still need more time to follow. Here on the other side, what we can learn from this graph here is that if you are treated, you being the Hunter syndrome patient, if you already have pretty significant cognitive delays at the time of treatment, the best you can do with this gene therapy is probably stay about the same level. So on one hand, it is encouraging that you're not seeing a lower trend because that means you're losing developmental milestones. But on the other hand, it really looks like these kids, for example, this is a 6-year-old, at the time of treatment had an age equivalent of about 18 months. And really after even, 3 years of follow-up has stayed about the 18-month level. So they've neither lost nor gained milestones. So the efficacy with regards to cognitive development isn't quite so good for patients who are treated after they've fallen way, way behind. So that's kind of the conclusion from this slide. So for part one, really, it was safe, well tolerated. You reduce the heparan sulfate to levels that are seen in patients with non-neurologic Hunter syndrome. Continued acquisition of developmental milestones in the kids that were treated very early before they developed cognitive decline or cognitive delays. And many patients have actually gone off intravenous enzyme replacement therapy because now their bodies are able to make enzyme on their own. Here's part two. So there were 10 patients enrolled. Again, you see this graph where there's the very high D2S6 in patients who have severe neurologic Hunter syndrome. Here are the non-neurologic, and then Hunter syndrome patients, and these are the normal patients. So this was the dosage that was used. And in these 10 patients, again, went from very high heparan sulfate levels and reduced by 86% up to at 16 weeks post-dosing. Obviously, this is the most recently dosed cohort, and so data have not been reported, but hopefully with additional time, these will get reported. So in terms of adverse events, we covered this: safe and well tolerated, no serious adverse events related to the gene therapy or to the procedure. We saw the significant reduction in heparan sulfate into the range of attenuated patients, and a benefit to development in kids that receive their gene therapy before the development of delays. The brain MRI brain size hasn't been reported. Neither have the CSF or the enzyme levels, only that we know that a good number of patients have actually stopped enzyme replacement therapy. So REGENXBIO, as you can tell by their stock performance, is running out of capital. But not too long ago, they announced what's called a strategic partnership, where this company called NS provides REGENXBIO with enough capital to sort of continue running. They have applied for what's called accelerated approval for RGX-121. This is a biologics license application, and essentially the FDA is supposed to review this application and decide whether or not to grant accelerated approval. Now, what does that mean? It means that if it is granted, if approval is granted, then patients with MPS II who fit what's called the label, and the label's a little bit up in the air at the moment, but it will probably only be patients with severe MPS II. They will be granted the eligibility to receive RGX-121. They will continue to gather data about cognition, about D2S6, about all these safety parameters. And if after review of additional patients, there shows continued efficacy, review of all the patients that were dosed many years ago, then the FDA will maintain its approval. If there are signs that it's not working or the efficacy wanes, the FDA may actually rescind, take away the approval. That's what accelerated approval process is. What I want to emphasize right now, it's still under review. We don't know if it's approved or not approved. We may not find out about this until later this year. Okay, the second study is called autologous ex vivo gene-modified hematopoietic stem cell transplant in MPS II. Oof, that is a mouthful, isn't it? It's being done at the University of Manchester. Very similar goals, looking at safety and tolerability, looking at how much enzyme patients make after their treatment, measuring heparan sulfate, and also studying neurodevelopment. So again, the target is neurologic or severe MPS II. The idea is to see if this treatment can help patients with neurologic MPS II continue to grow and gain skills without needing to go back for enzyme replacement therapy. So number one, a little bit of background. I talked really quickly about stem cell transplant. This is a little bit different. This is what's called autologous stem cell transplant. And in this case, the stem cells are actually coming from the patient themselves. So the donor is the patient. And you're like, well, how does that work? They have Hunter syndrome. Well, the idea is you can actually pull out the stem cells, and then you can give gene therapy to those stem cells while they're outside of the body. The vector equips those stem cells with the ability to make IDS enzyme. And then you give those treated stem cells back to the patient. And if all things go well, the idea is that patient is cured for life. Of course, you do need to make a little bit of room for those new stem cells to find a place to live, to engraft. But the benefits are you don't need quite as much chemo. So you don't need to give super high dose chemo to eliminate the patient's existing immune system. And because these are the patient's own stem cells, there's a condition called graft versus host disease, where those stem cells, if they don't recognize where they're living, may actually attack the patient. You don't want that. And because these stem cells come from the patient themselves, the risk of GVHD, graft versus host disease, are pretty much eliminated. So there are a lot of strengths for this. The other thing that's really cool is that the gene therapy enables these stem cells to crank out tons of enzyme, including the brain and possibly even the joints. And so at the moment, um, uh, actually one patient has been dosed, and that's my patient. We don't have a whole lot of data about that, so I'm going to walk you briefly through a very similar study, which was autologous gene therapy for MPS 1, for severe MPS 1, also called Hurler syndrome. But with permission, this is Q Ollie and his older brother, Skylar. He's my fan club, which is really cool. This is Dr. Jones in Manchester and his colleagues. And I'm very happy to say that Ollie got his autologous stem cell transplant a few weeks ago. Things went very smoothly. He's engrafted, and I'm very, very hopeful that he's going to start to make enzyme on his own, but I have no data on that. So I'm, obviously a little bit invested in this. I really do want to see this work out well for Ollie. So after you give chemotherapy, you need to wait for your blood cell counts to come back. And so in these 8 patients, they averaged anywhere from a little under 2 to 3 weeks for their platelet counts to come back. And again, also about 2 to 3 weeks for white cell counts to come back. This is actually pretty fast. And the lower the recovery time, the faster it is that you don't need platelet transfusions, for example, and the faster your immune system comes back. Really, there was only one adverse event, serious adverse event out of 19 that was related to the stem cell transplant, which is an allergic reaction. The rest were really either related to disease or other things like infections, and no events related to immunosuppression. So fairly safe. The really neat thing, so patients with MPS are often short-statured, and you can see that these patients, which are treated very early on, before 12 to 24 months, grew really well, both boys and girls, and their stiff joints actually increase. So as the numbers go up here, that's increasing range of motion for the shoulders. Flexion is sort of moving your shoulders forward. Abduction is moving your arms away from your body. And this is knee extension. And it's really neat to see that some of these patients, which had fairly stiff joints, actually increased in mobility over time. Here, if you look at their enzyme levels, this is pretty exciting. Even after 1 month of the stem cell transplant, their enzyme activity in blood is either at the upper limit of normal, even more than normal. Oftentimes for these treatments, the more, the better. You can see for their GAG levels, this is another GAG called dermatan sulfate. This is for heparin sulfate. These are all in the urine, so we're not looking in spinal fluid, not yet. You can see that the GAG levels have come down. Most of them are within normal range. And within the brain, in the cerebral spinal fluid, enzyme activity has ranged either from about 10% of normal, so these are the 0.1s here, up to about 100% of normal over here. So exactly normal levels, and GAGs within the CSF were also reduced anywhere between 3/4 to about, what is this? 1/16th. And that's about twice normal. So kind of like the RGX-121 study, yes, the GAGs were reduced quite significantly, but the lowest levels are still quite a bit above normal. Here is the developmental age, and if you recall that if you're on track developmentally, your chronologic age will match your developmental age, and that's this red line here. And you can see virtually all the patients that were treated with autologous stem cell transplant continued within the normal range. Now, I need to emphasize that this is Hurler syndrome. You have to do the study for MPS 2, but because of what happened with these MPS 1 patients, that gave me confidence enough to refer my patient over to Dr. Jones in Manchester for the MPS 2 study. So to summarize, autologous hematopoietic stem cell transplant gene therapy for Hurler syndrome was safe and well tolerated. There was only one serious adverse event, an allergic reaction treated with antihistamines related to the transplant itself, but that was treatable and resolved on its own. Normal growth and development, normal mobility of the shoulders and the knees. Enzyme activity in the blood is far above normal, so obviously they stopped their enzyme replacement therapy. Enzyme levels in the spinal fluid were anywhere between normal and 10% of normal, with significant reduction in spinal fluid that's still elevated, but quite a bit lower than they were. And again, to date, normal neurodevelopment. All of these children received their autologous gene therapy transplant before age 2 years. So I hope I didn't run over time. I may have, and if that's the case, I apologize. I just want to say this is super exciting, but obviously a nerve-wracking time for MPS 2 gene therapy. I just want to say that, this is one of the reasons I went into medicine, and specifically for lysosomal storage diseases and MPS specifically, is that, years and years ago when I started, severe Hunter syndrome was termed incurable. Right? Once you were diagnosed, there was nothing you can do. People had no choice but to watch their children sort of slowly decline cognitively. But it's really neat that not only do we have one, we have multiple clinical trials in effect right now for treatment of neurologic hunters. I do think that changes with the FDA have made pathway to approval of therapies easier than they were even 5 years ago compared to now. But there are pretty significant challenges for rare disease treatments. I just wish, we could just fast forward to the point where we knew what the study results were. But I'm still super optimistic that the way we treat Hunter syndrome, especially severe Hunter syndrome, is going to be super different than the way we treat it now. And we're just on the cusp of finding out what's going to work. And so with that, just wanted to thank you all for your time, for your attention, and happy to take any questions that you have. Okay. Look forward to chatting with you live.
Problem. Okay, so here is your first question. It is, will gene therapy be only for severe MPS patients, or do you suppose, I guess, that attenuated patients would be able to receive it as well?
Yeah, that's a great question. I think because the unmet need for severe MPS is really great at this moment, I think the focus right now for gene therapy programs is to get something approved for severe MPS first. And, you just need to get a foot in the door. I'm hopeful, actually pretty confident that once something is approved for severe MPS, then there will probably be additional studies. So they're actually, well, I don't know. You never know. You know, either it will go straight to becoming approved for all patients with Hunter syndrome, or there's a possibility that the FDA may mandate a clinical trial for attenuated patients. I don't know how the FDA thinks. It may depend, but I'm pretty sure that there will be gene therapy for attenuated patients.
Right. And I think that's part of it too, is understanding that a lot of those determinations happen with the FDA in terms of what label is approved. And unfortunately, no one but them has that power to make that decision.
Yes, exactly.
And kind of leading into that, and I think it'll be a pretty similar response. But do we have any, I guess, theory on what the age range will be for gene therapy?
So again, not able to read the FDA's mind, but generally, the way that the FDA approves things is according to how the clinical trial was structured. At the moment, the campsite study was for, there were patients that were treated that were past 24 months of age. Perhaps the cognitive outcomes were not as clear cut and positive as the younger treated kids. But it's possible they'll approve it for the age range that was done in the clinical trial. On the other hand, and this is for Sanfilippo, so it's for another rare neurologic MPS, it looks like Ultragenyx, which is doing the clinical trials for MPS 3A, is seeking a label for all ages. So I think it's anyone's guess. Obviously, we hope for a broad range.
Right. And quickly, can you talk about how the process works? So we know with the standard ERT that there's a certain age range on the label, but certainly many of our kids have received ERT outside of that when they've been much younger than the label says. How does that process work? Is there a time allotment that takes place before doctors can prescribe?
Well, I think the insurance company will look at the label and say, oh, your child doesn't fit the indication. They may actually deny it at the outset, but it's kind of our job as the MPS doctors and experts to write letters, to appeal decisions if they're denied, and say, look, and then we have to provide publications. So this is where publications actually become really important. You have to provide some sort of form of proof or justification to say, hey, early treatment actually prevents a lot of these things from happening. So it's really in your interest as the insurance company to approve this so that you don't end up having to pay more later on. I mean, the label for Elaprase is really silly. You have to be able to do a pulmonary function test, which I think very, very few children are capable of doing. So, yeah, it is our job and our responsibility to appeal any denial decisions.
Absolutely, yes, and that is why we're working on some payer education publications to help with that process.
Yep.
Another question for you is, and I'm just going to read this out completely. It's interesting that the third dose, this is referring to REGENXBIO's clinical trial, was so much lower than the second dose, yet had better HS reduction, heparan sulfate. Showing more is not always better. How is that explained? Less immune response at the lower level, but better efficacy than the initial lowest dose?
Um, I thought phase 2 was the high dose, 5 times 10 to the 11th vector genomes, but I could be wrong.
And you might be right, and we, whoever asked the question saw that incorrectly. So you're saying that the chosen dose was the highest dose?
Yeah, can I get back to you on that? I think it was the
Absolutely.
highest. And if it's not, I will text you and let you know. But
Perfect.
sometimes more is not always better. But I think in this case, they were trending on the high end of things. But again, I could be wrong.
Perfect. I will make sure to put that in the lobby chat to follow up with the confirmation on that
Okay,
answer.
will do. Yep.
And let's see, trying to see if some of these are maybe a little bit outside of the scope of what this was talking about, but just in case, so, you should know these answers anyways, Dr. Wong. I know you've given our treatment landscape talks in the past, so can you, and maybe you don't remember these offhand, so apologize for kind of getting you off topic here, but can you talk about which clinical trials are available for children with MPS II severe form who are older, including adults?
I think at the moment, um, this information may be a few months out of date, but because I haven't looked recently, should have been better prepared. But I think that JCR, so JCR has a enzyme replacement therapy that's actually came before Denali's DNL 310. I think it's called JCR 143. I could be wrong. Um, but it's a intravenous enzyme replacement therapy with the ability to cross the blood-brain barrier. Um, uh, I sent a patient to Children's of Oakland a few months ago. They might still be enrolling. I would look on clinicaltrials.gov for JCR and Hunter syndrome and see if they're still enrolling.
Yes, and that is a great tool for all of our families out there, clinicaltrials.gov. The first thing that you do, because it is a little confusing, is you can type in the disease. You just start typing in muco, and you'll see it pop up, mucopolysaccharidosis type 2. And you can click on the option for recruiting trials, and that will bring up everything that's currently recruiting. And you can find JCR's, which is JR141, and also Denali's trial, which is enrolling. Their clinical trial does go up to age 26 now. That's kind of a new cohort, so you can find that information there. And the other clinical trials, as we know, Regenix Bio is not enrolling right now. They're in the process of filing for approval. And the Manchester study that you talked about is for patients much younger. I believe it's under 24 months or so.
Yep. Yep.
Mhm. Perfect. Okay, great. And I see one other question too. I will go ahead and answer since it's here. I don't think that this is going to be your area, but it's referring to children on IT, Elaprase, and whether or not they will be able to continue receiving this treatment. So just to clarify, that is a clinical trial that is no longer happening technically. So the patients who were in IT are still getting access to IT, but they will not be enrolling, and they are not planning to ever have approval for that treatment. So those of you who are in that study or were and are now in the post access, you will continue to receive your treatment according to Takeda's most recent word. And as you all know, you still are receiving that. And the plan is to continue to have access to that therapy until there is something appropriate for your child that is approved by the FDA. So that may be something that's done on a case-by-case basis. We should know more on what their process will be as things move along and as things become more of a reality rather than if they get approved, right? So
Super.
great. Well, thank you so much, Dr. Wong. We really appreciate it. It was a really great presentation, and we always enjoy having you here with us. So
Thank you
thank
for,
you so much.
yep.
All right. And I will see everyone else back in the next session. So see you there. Bye.